C. Esophagus, and we will kind of compare it with C. stomach because they are not very dissimilar. And C. esophagus is normally, there are two types, either it's a squamous cell carcinoma or it's a adenocarcinoma. Squamous cell will be seen in the middle third, which is usually the most common type. At least in India, it is squamous cell. In the Western world, which is seen in the distal third, is going to be adenocarcinoma. It happens in the setting of Barrett's. Now, why do I get C. esophagus? For that matter, any GI cancer, risk factors are very similar. Smoking, spirits, sepsis. Sepsis means infections and diet. You will see in all the 4 GI cancers very similar. Now, smoking means tobacco in any form. Spirits means alcohol. Sepsis. What is sepsis? Sepsis means esophageal infections. Important infections in the esophagus are human papilloma virus, not H. pylori, that is in stomach. So one is human papilloma virus, other is esophageal candidiasis. They are pre-malignant. D for diet. Diet is consuming foods rich in N-nitroso compounds. Example is pickled foods. So if you consume a lot of pickled foods, they are carcinogenic. Then you should know the pre-malignant lesions. Now in esophagus, you can get squamous cell carcinoma. One pre-malignant lesion we have studied is achalasia. Other important pre-malignant lesion you've just studied is corrosive injury. Any severe injury or persistent injury increases the risk of malignancy. That is what you should know. Right? So chronic irritation causes all these cancers. Adenocarcinoma, very important. Now don't mark this differently. It is going to be Barrett's. So Barrett's will cause adenocarcinoma. Barrett's. Smoking can cause both. Obesity, GERD are all going to be risk factors for adenocarcinoma. Right? Now if you compare this with stomach, the risk factors are very similar. Smoking, spirits, sepsis is the same, but sepsis here is not candidiasis. Obviously, for stomach it will be H. pylori infection. Okay, for stomach it will be H. pylori infection, which causes type B gastritis. Okay, it will cause type B gastritis. And it is a WHO class 1 carcinogen. Stomach diet obviously is important, consuming a lot of smoked foods, consuming foods which have a lot of soya sauce. That's why this is so common in Japanese. Consuming a lot of sushi. So these are some risk factors. So CA stomach, commonly seen in the Japanese population. And CA stomach is a type of adenocarcinoma. Now in stomach there is no squamous epithelium, right? It is adenocarcinoma. Right, that is the most common type. Pre-malignant lesion for CA stomach, very important, the ones that you should know. One is going to be peptic ulcer. Then there are some polyps in the stomach like adenomas. Now these adenomas are more common in colorectal cancer, but they can be seen in stomach also. And some rare conditions like atrophic gastritis or hypertrophic gastritis, also known as Menetrier's disease. So atrophic or hypertrophic gastritis, but they are luckily quite rare. So these are the types or risk factors for stomach cancer. Now understand, how does a cancer look? You'll understand first better on stomach. Now in stomach cancer, there is a classification for advanced gastric cancer that is called Borman. So Borman looked at advanced CA stomach. Advanced means muscle invading. And based on their physical appearance, he divided them into polypoidal type, ulcerative type, ulcero-infiltrative type, and diffuse type. So these are the 4 types of CA stomach grossly, which are advanced. Advanced means muscle invading. Now you're like, sir, why do we need to know this? What is the big deal if they are this or that or this or that? Understand, based on the type, you can predict the clinical presentation. Like type 1 or polypoidal type, it is likely to cause a lot of bleeding because it's like a cauliflower. So it will cause a lot of upper GI bleeding symptoms. Type 2, which is ulcerative type, will cause dull aching pain. It will mimic a ulcer. Infiltrative type, if it is present in the distal stomach, will cause a non-bilious vomiting due to gastric outlet obstruction. It will cause a non-bilious vomiting due to gastric outlet obstruction. And type 4, the diffuse type, also known as linitis plastica, is going to cause early satiety because it will cause a reduction in the gastric distensibility. So person will feel full after barely any meal. So these are some of the cardinal types and the cardinal presentations of CA stomach. If you think of it like this, pathology makes a lot of sense. Now similar types can be seen in esophagus, but they are not given any name, luckily. So in esophagus also you can get a fungating growth, infiltrating growth. They are all going to be seen, and based on that type you will get the symptoms. Now the golden rule, whenever I study these GI cancers, the first thing I should say is, in what category of patients will I see them? Very important, remember these golden words. Whether it's esophagus, stomach, colon or rectum, they are typically going to be seen in elderly patients. Yes, nowadays young patients are also getting malignancies, but typically elderly patients, more common in males, males more than females, and typically they will have history of smoking. So I always use this short form, elderly male smoker or elderly smoker male. You see these words in your MCQ, think of a malignancy. So even stomach cancer, for that matter, is always going to be seen in elderly male smokers who will come with either a upper GI bleed or a non-bilious vomiting or early satiety. Now what will be seen in C esophagus? It's very simple. You will see dysphagia. This dysphagia is going to be given the words painless, progressive, and it will be more to solids. Painless, progressive, more to solids, at least initially. Contrast this with achalasia or motility disorders. There it was more to liquids. Here it is more to solids because solids won't go through the malignancy. Liquids will pass. Second thing you will get is, here also you can get regurgitation. He will say food comes up. This person obviously because of malignancy will end up losing weight. So if you notice in achalasia we had the same three symptoms: dysphagia, regurgitation and weight loss. There it was called triad of achalasia. Here I will call it pseudo achalasia. Okay, this is called as pseudo achalasia. So if anybody asks you pseudo achalasia is seen in, it is seen in C esophagus. So don't say it's a variant of esophagus of achalasia. No, it's not a variant of achalasia. It is symptoms of achalasia seen in malignancy known as pseudo achalasia. These will be the typical symptoms. Apart from this, you can get features of esophagus causing a spread like a malignant metastasis. Like the tumor may infiltrate the trachea or the left bronchus. Tumor may infiltrate the aorta, it may infiltrate the stomach, and so on and so forth depending on the location. So there will always be findings of metastasis. There can be lung mets. That is hematogenous. So these kind of findings may be seen clinically or on evaluation. Similarly for stomach, apart from an elderly smoker male presenting with either upper GI bleed or weight loss or non-bilious vomiting, there are some typical findings you should know, and these findings are not specific to stomach cancer. They are common in stomach cancer and they imply metastasis. Some very famous terminologies you should know implying metastasis of stomach cancer, like Virchow's node. It is an enlarged left supraclavicular lymph node. Now you will be like, how stomach cancer and left supraclavicular lymph node? It is a metastasis. Okay, if I see stomach cancer patient who has an enlarged left supraclavicular lymph node, it means he has a metastasis. Metastasis means his TNM stage will be M1. Sometimes patients get nodules around the umbilicus. They are called Sister Mary Joseph nodules. These are paraumbilical nodules. These also imply metastasis of CA stomach to the umbilicus or to the subcut of the umbilicus. You can get Krukenberg tumors. These are bilateral ovarian metastasis. Then there is one more not very common, iris node, which is the left axillary node. Okay, so these are some of the markers of METs. If any of this is there, usually in stomach cancer, but can be in other GI cancers, it means it's an M1 disease. So in a nutshell, elderly smoker male with progressive dysphagia, you think of C esophagus. Elderly smoker male with upper GI bleed or blood in stools occult blood in stools, non-bilious vomiting, you think of a CA stomach. That should be the clinical stem. Now the easy part. Don't study these diseases individually in terms of investigations because they are all upper GI diseases. How will you confirm the diagnosis? First step or the IOC will be UGI scopy. And when you see the tumor, you do a biopsy. Right now, see this image, easy to understand. You can make out it's not esophagus, it is stomach. This thing that you are seeing here, this is the pyloric opening. So the tumor is just proximal to the pylorus. So it is a tumor in the antrum. If I ask you most common site of stomach cancer, it is the antrum. And the reason is because H. pylori hides in the antrum. Okay, in Japan where there is not so much H. pylori, it is not antrum. There it is proximal stomach. So I do the endoscopy, I see the tumor, I take 2-3 biopsies. Biopsy will prove it's a adenocarcinoma of the stomach. In esophagus, it could be either squamous cell or adenocarcinoma. Once I get the diagnosis, the next step is going to be I want to look for METs because in both of these malignancies, all these different METs are possible. Clinical or on imaging. So I need to do imaging for METs. That is called as staging. Two types of stagings are done in all cancers. One is called local spread. Local means I want to know the depth of invasion. Is it going into the muscularis, into the serosa, or is it going into adjacent organs? For that local spread, for esophagus and stomach, it's the same. I am going to do endoscopic ultrasound, EUS. For distant spread, I am going to do PET scan. So for esophagus and stomach, my pathway of investigation for CAs is the same. Confirm with a biopsy, local spread, EUS, distant spread, PET scan. PET scan will tell me, are there lymph node mets? Are there any distant mets? EUS will tell me depth of invasion. Right. So all this I will come to know. When I do all this, I will finally get the diagnosis and the staging. The staging is going to be the TNM staging. Okay, I will get the TNM staging. And students are always worried, sir, TNM, how to remember? So many are there. It will be very simple. For GI cancers, there is a fixed type of TNM. For hepatobiliary, some cancers have important TNM. For urology, I'll tell you the tricks. Okay, and then of course there is breast cancer. These are the IMP cancers whose TNM in surgery you must know. Right. So, what is this TNM? T here stands for depth of invasion. N stands for nodal mets, M stands for distant mets. At least you should know the T stage, and it's quite simple. There is one simple logic. Depth of invasion means what? If there is an organ, like let's say esophagus, it has those layers, mucosa, submucosa, muscularis, and the fourth layer in esophagus is adventitia. In stomach, it is serosa. And then there are adjacent organs, like here there will be left bronchus, for example. Now, tumor arises from the epithelium, that is mucosa. Depth means where will it go? Depth means it will go submucosa, muscularis, adventitia, adjacent organs. That is the T stage. Okay, if you know this much, your life is sorted. Okay, that will be the T stage. So for esophagus and for stomach, it's very similar. T1A, tumor invading mucosa. T1B, mucosa, submucosa. Remember, this is what I saw on EUS. I don't see this on biopsy. EUS will tell me depth of invasion. T2, invading muscularis. T3 for esophagus, the next layer, was invading adventitia. So T3 is adventitia for esophagus. T4A, it is invading adjacent organs. But these organs are ones which I can resect. They are resectable adjacent organs. Example of resectable, if the tumor has gone in the pleura, or if the tumor has gone in the stomach or in the diaphragm, they can be partly resected. But T4B, adjacent organs which are unresectable. This you know, I already told you where esophagus cancer can go, which is unresectable. If it's in the middle esophagus, it can go into the trachea, bronchi, aorta. Obviously, that becomes unresectable. Right. So, the depth of invasion, all this I will see on EOS, and that will tell me the T1, T2, T3, T4 stage. For stomach, it's very similar. In fact, T1A, T1B, T2 is the same. Now understand, stomach does not have any adventitia. So T3 for stomach is not adventitia. Stomach has a serosa. T3 is called as invading subserosal planes. T4A will be breach of serosa or breach of visceral peritoneum. They mean the same. Breach of serosa or breach of visceral peritoneum. Serosa and visceral peritoneum for the stomach are the same. And T4B is going to be invading adjacent organs like pancreas. Right. So when you are studying these topics, no, you should only know these differentiating factors in the T staging. N staging is not that important to memorize. M means M0, no distant mets. M1 is distant mets. So Krukenberg tumors, lung mets, liver mets, stomach often goes to the liver. So those kind of mets will be picked up on the TNM staging. Right. So remember at least the T staging of these cancers. M is M0, M1, N is not that important. You get this, the other GI cancers will follow suit. Okay, this is what I'm saying. Know this much of logic. Another very important concept that you need to know is the treatment. Now understand, when I say treatment for cancers, I don't look at T1, T2, T3, T4, different treatment for each in GI. I simply divide the cancers into 3 categories. One is called as early cancer. Early means I can remove it. And this you use your common sense. Don't try to memorize it. Normally, early cancer for esophagus and stomach is going to be T1, T2. Okay, just know this much. Don't try to memorize each stage. Not possible. If it's an early cancer, T1, T2, mucosa, submucosa, muscularis, I will go and remove it. Means I will first do surgery. And many times after surgery, we give chemotherapy in GI cancer. So I will give a adjuvant chemotherapy. So whenever you get any question on a malignancy, first know is it an early cancer. Early cancer, surgery followed by chemo. If it's an advanced cancer, advanced usually will be T3, T4 usually. It's not hard and fast, but I'm just telling you simply. If it's advanced, means it is stuck to adjacent organs, I can't take it out. I want to make it smaller, first downstage it. For that, I will give chemotherapy that is called as a neoadjuvant chemotherapy. Neoadjuvant means prior to surgery. That is called neoadjuvant chemo. If the tumor gets downstaged, patient is lucky, you are lucky because now you get to operate. Now you will do surgery. Right. So for locally advanced cancers, first chemo, then surgery. If it's metastatic means M1. Person has lung mets, liver mets, Krukenberg tumors, or Virchow's node. If any of this is there, I can't operate. I will do palliation. Palliation simply means improve the quality of life. Like if it's a esophageal cancer and person is not able to eat, then what can you do to improve the quality of life? Maybe you can put a stent, or you can do a feeding gastrostomy or a feeding jejunostomy. These are just methods of palliation. For the time that he will live, he will be able to eat. That's it. So this is the first step of deciding the treatment for any malignancy. Now you look at the individual cancers and then you do the surgeries wherever it is permissible. For example, if it's a C esophagus, when the tumor, wherever it is located, let's say the tumor is over here, I am not just going to remove the tumor. I will remove the tumor with some margin of normal tissue, proximal and distal. I am also going to remove the lymph nodes. This kind of a surgery is called as a radical surgery, where you do a wide excision with a margin and the lymph nodes. So for each of these cancers, I should know the margins first. So for esophagus, what is the margin proximally? It should be more than 10 centimeters. It's a big number. Means if the tumor is, let's say, in the middle esophagus, 10 centimeters proximally, I have to remove the esophagus all the way. So I have to remove a big chunk of the esophagus. Distal margin should be more than 5 to 10 centimeters. Now these numbers are 2. If the tumor is in the middle esophagus, you will take 10 centimeters. If it's near the stomach, you go till the stomach. That is 5 centimeters. Okay. So here there are 2 numbers. Proximal is more important, that is 10 centimeters proximally, 5 to 10 centimeters distally. You will do a resection like this with the lymph nodes. That will be called as a radical resection of the esophagus. So you remove this along with the lymph nodes. This is called as radical esophagectomy. That is the surgery for CE esophagus, radical esophagectomy. Now after you are resecting, you have to do the joining. And the problem is esophagus spreads from the neck to the chest to the abdomen. So to remove so much esophagus, there are two approaches that you should know. There are many, but these two are the important ones. The first one is called the Ivor-Lewis or the double approach. This is done for distally located tumors, where I will take two incisions. One is in the abdomen, other is in the right chest. So this is done for distally located esophageal tumors. That is called Ivor-Lewis. So this is a double approach, abdomen and right chest. You go inside, remove the esophagus with the lymph nodes. However, if I want to remove a big chunk of the esophagus, maybe all the way till the thorax and into the neck, if I also want to remove the cervical esophagus, I will do a triple approach, that is called McKeown. So McKeown is nothing but a combination of Ivor-Lewis and a left neck incision. So there are three incisions. That's why it is called as triple approach. Students, remember it as in McKeown there is a McKeown incision. You can remember it like that. So in McKeown there is a neck incision or a McKeown. So I'll take such an incision, remove most of the esophagus with the lymph nodes, and after the resection I have to do an anastomosis. And if I ask you how to do the anastomosis, like a big chunk of your esophagus is gone, maybe you have little esophagus left here and little bit of stomach left here, what anastomosis do you do? The best anastomosis I can do is I can pull up the stomach into the chest and do the gastroesophageal anastomosis. That is called as gastric pull up. So if I ask you the anastomosis of choice or the conduit of choice, it will be a gastric pull up. I have to pull up the stomach that you are seeing in this image. This is a gastric pull up. I pulled up the stomach and joined it to the remaining esophagus. If this is not possible, I may have to put colon in between. That is called as colonic interposition. Disconnect a piece of colon, join it proximally to the esophagus, distally to the stomach. Okay, it has to be disconnected. And then the rest of the colon you have to anastomose to maintain the continuity. So that is called as colonic transposition. Okay, but for us the important one is gastric pull-up. That is what you should know. So this is how you will manage CE esophagus. If you understood CE esophagus, CE stomach is even easier. Because in stomach, there are no approaches. You have to go in the abdomen only. And here also there are margins that you should know. So if the tumor is in the distal stomach, for example, which is usually the side, tumor is over here, your proximal margin here will not be 10 centimeters, it will be 5 centimeters. And the distal margin here will be till you finish the stomach, that is till you reach the D1. So for stomach, proximal margin should be more than 5 centimeters. Distal margin is usually till first part of duodenum, till D1. You resect all this, you also remove the lymph nodes. So here you are going to do a radical gastrectomy. It can be a subtotal or a total. If you have removed the full stomach, it is a radical total. If you have left some stomach, it is called radical subtotal. But you will do gastrectomy, means remove the stomach with the tumor and the regional lymph nodes also. That's why it is called as radical. Now there are two numbers you should know. What lymph nodes I remove, the extent of lymph node removal is given by some numbers. That is called as D1 or D2. Remember here D1, D2 is not a duodenum part 1, part 2. D1, D2 is talking about how many lymph nodes I am removing in the vicinity. D1 means I am going to remove lymph nodes in the vicinity which are given the numbers 1 to 6. So different lymph nodes are given different numbers. Like lymph node over here, right of the upper stomach, right paracardia is called station 1. Left paracardiac is called station 2. Lesser curvature is called station 3. Greater curvature is called station 4. Suprapyloric is called station 5. Subpyloric is called station 6. If I remove all of these lymph nodes in the vicinity, it is called as a D1 lymphadenectomy. But understand, normally I don't just remove these nodes. I remove some more. Some which are near the gastric artery, near the spleen, near the liver. My extent of lymphadenectomy goes a little further away from the stomach. That extent is called as D2. D2 means I will remove numbers 1 to 6 first, which are my perigastric nodes. They are definitely going to be removed. So D1 is definitely going to be done. In addition, I will also remove little distant lymph nodes, which are going to be given the numbers 7 to 11. Okay, so when I say D2, this is what is done normally. I remove lymph nodes numbered 1 to 6 and 7 to 11. So when I say radical gastrectomy, it is usually radical gastrectomy with a D2 lymphadenectomy. Okay, D2 here is not duodenum. D2 here means the stations that I am removing are these 1 to 6 and 7 to 11. And after this, I will do the anastomosis. The anastomosis for stomach is very simple. I will join the jejunum to the stomach. So anastomosis is going to be gastrojejunal anastomosis. Job is done. Esophagus, I required some conduit, like a gastric pull-up. Here, that situation is not there. I can pull up the stomach, I can pull up the jejunum and join it to whatever stomach is left. That is called as a gastrojejunal anastomosis. After both of these cancer treatments, I am going to give adjuvant chemotherapy, and the chemotherapy uses a very important drug that is called platinum. Remember this. Cisplatin, oxaliplatin are a part of chemotherapy for esophagus and gastric cancers, right? So in a very simple way, I have summarized the two most important GI cancers, and all the important points are covered for you to get the answer in the exam.